Hello and welcome back to the Neurotransmitters, your podcast about everything related to clinical neurology. Today I am joined by Chris Cantrell from the Cleveland Clinic Lerner School of Medicine, a student there, I should say. I don't want to, have any, false accreditations, as it were. What's the term I'm looking for? Stolen valor. But Chris and I met through some mutual contacts at the American Academy of Neurology meeting this last spring, and some other mutual friends. And he's got some interesting experiences that I thought would be potentially educational and beneficial for you, our dear listener. And today we are talking about talking, or communication as it would be more properly understood. So Chris, welcome to the podcast.
Thanks for having me, Dr. Kentrell. Excited to be here with you.
So I was very interested, anyone who knows me knows that I'm always interested in the way that we communicate things. And I think Shakespeare probably said it best, right? Brevity is the soul of wit. But in medicine, perhaps short is not always the sweetest. So tell me a little bit about how you came to be interested in the art of communication in a medical setting, and kind of how your school also fostered that ability to develop those skills.
So I'm, like you were saying, still a medical student, fifth year now at CCLCM, planning on applying into neurology, hence why I'm on this kind of podcast topic, I suppose. But my interest in communication really came about as part of my med school. So there's a culture of self-reflection that they try to instill in their students from really early on. It's taught. It's not just talked about, because it's really a skill that's to be developed. And so early on in my first and second year, kind of experiencing that powerful benefit of strong communication in teaching, and from my colleagues as well, or my fellow students, and seeing how much that helped me to improve. And then on the other hand, as I aged in med school and starting to teach some of these younger med students who are just learning how to do these things, seeing how much it helped them to try to use those same tactics and kind of evolve and keep improving myself as a teacher, and seeing how much they benefit from that, and in their own interactions with patients as well, like coming back and telling me, hey, I tried this thing that we talked about and it seemed to work really well. So that's where I realized how important communication is as a teacher, as a sort of practitioner of medicine at this stage. We're getting there, but it really made me more interested in it, and to keep kind of thinking about it as a core principle of medicine and just being, I guess, a human.
Yeah, that is one of the things that I think gets neglected, all through. I think this is a universal experience for everyone who goes through medical training. Is you're kind of the fly on the wall as a medical student, and you're watching a patient encounter, a conversation with the physician that you're shadowing or rotating with, and you're just like, ooh, this is really awkward and painful to watch. And I think it speaks to what you're saying, right? These soft skills, quote unquote, are something that's like, oh, well, you made it in med school, you're at least semi-intelligent. So certainly you can talk to another human being in a rational and reasonable way. Mm-hmm. Not so much the case, right? This is a skill that needs developed and worked on, just like any other kind of ability.
Yeah. So early on in our med school, they get us started in a communication skills course. So there's two phases to this. There's the first year course and the second year course. That first year course really focuses on just the ground level basics, fundamentals of how to introduce yourself to patients, how to set up what's going to happen in the visit, how to introduce yourself even just as a medical student, and to not be shy about that, or feel like, oh, I shouldn't be talking to you because you're really here to see the doctor. The basics of the history. How do I do a social history? How do I get an HPI? Things like that. How to deal with patients who might be on the chatty side and redirecting without being rude. That's one of my favorites. One of our standardized patients is the archetype of the grandmother who wants to give you cookies and be like, oh, well, I'll bring by cookies for you. How do you redirect from that? So
You ask what kind of cookies? That's the real
oh,
question.
exactly. So all these kind of situations we throw students into, it's all in a small group setting. And you're getting feedback constantly from your peers as well as faculty preceptors and or a student preceptor, which I was lucky enough to serve in that role last year as a student preceptor. And then in your second year of med school, they go on to kind of more advanced skills where you get into more motivational interviewing, smoking cessation counseling, delivering difficult news, things like that, where it's you really don't want to be learning how to do it on the job.
Absolutely. Now, motivational interviewing is something that we hear all the time. We're seeing it instituted in a lot of, not just in medicine, but in a lot of the allied health specialties as kind of a training curriculum. But what do people mean when they say motivational interviewing?
So for me, I think of motivational interviewing as, right, so it's an interview. We're still trying to get information, but there is some kind of goal behind the questions that we're asking. You're still taking your cues from the patient, but ultimately we're trying to direct them towards some sort of better health outcome. And I think the reason I like the kind of motivational interviewing name for this skill is that it really does come from the patient. It's like, to use the example of smoking cessation counseling, it's evaluating how ready are they to make changes, what stage are they in, what would it take to get to the next stage, and kind of taking that longitudinal approach of not, okay, I'm just going to tell you to, you need to stop smoking, versus what's it going to take for you as a patient to be ready to make these kind of lifestyle changes.
Gotcha. So in my mind, I almost envision it like a form of kind of like Socratic teaching, where you're asking them questions like, well, do you want this thing? Well, to do that thing, this is making it harder. This habit or lifestyle choice, or like, you don't like being in the hospital, right? But you don't take your medications very often. That, like, the medication adherence whole conversation, which is pretty universal. But yeah, it is kind of like, well, we have these two choices in front of us. This one's most likely to kind of lead to outcome A versus outcome B. If you want this other outcome, then you kind of ask them to analyze, like, how are your decisions leading you towards or away from what you actually want? Does that sum it up accurately?
Yeah, no, for sure. And I think that really gets at the importance of patient-centered interviewing. We talk about that as part of our training, our training in my med school. And, they are the center of everything. We can't force them to do things that wouldn't be particularly ethical or feasible.
Right.
So,
yeah. And I almost kind of link it in, right? We tend to think of the phrase, for those who work in medicine, right? Goals of care, right? Almost has like a connotation that we're talking about end of life, but that's not necessarily true, right? Like, I saw someone just recently following up, had a TIA, and I was like, oh, we should probably get some additional imaging to kind of make sure that we aren't missing anything. And he's like, I don't want any of that. And I was like, well, why not? And he's like, every time I have testing, they put me in the hospital. I'm just like, well, sure, I can understand that. But he was very adamant. He didn't want testing, et cetera, right? So those are his wishes. He has, capacity for decision making and so on and so forth. And so, while you may not agree, right, this is kind of going back to our principles of medical ethics. Like, he has autonomy and has the right to make his own decisions. And so it does become one of those things where you have these conversations, and yes, you aren't going to always agree with your patients. Like, that is 100% going to happen. And I think it's a question of, does this patient understand? Have I communicated? Right? To come back around to the theme of the show, have I communicated the information and the consequences or potential outcomes of these different paths in front of us? And as long as you've done the best that you can, then that's really all you're doing is providing advice. And that's, I think, a lot of where, a lot of physicians that I see, where they get really frustrated with patients and they make them sign out of the hospital against medical advice, and kind of these like semi-punitive types of actions, really just comes from a lack of communication about this.
Mhm. Well, then that gets in the way too of right the doctor patient relationship and
Absolutely.
how important that is to people. Whether they want to follow your advice or not. If they don't like you, they're
Mm-hmm.
not probably going to want to listen to you as much. So that stopping smoking or taking that medication that's going to keep them out of the hospital, they're going to view it completely differently if
Yeah.
you're not listening to them.
And I know a conversation that I'll often have when I'm rounding in the hospital is like I'll be going in to see Mr. Doe, and like like how's things going? It's like I want to get out of here. I'm like, well, no one's keeping you here against your will, sir. But I would recommend perhaps doing X, Y, and Z before you go, if you're willing. And we can kind of start off a conversation. But I'm always very upfront of like, I'm not keeping you here. No one's holding you here against your will. Again, right, assuming they have appropriate medical decision making capacity and all that. And I think that depending on if you have your kind of stereotypical old curmudgeonly man, that helps break the ice a little bit. But you got to read the room.
I was picturing the same guy.
Yes. And it's like his wife's sitting there. She drug him in here against his will. That's the usual scenario, right?
Mm-hmm.
But I think it's important to make sure that you do educate people about their options. It's like if they know that they can leave, if they really don't want to be here, that does, I think, at least subconsciously help them buy in a little bit to getting what tests you recommend and things of that nature, so that you can move towards hopefully mitigating those risks and providing them appropriate medical treatment. Again, that's my totally non-evidence-based perspective, just from clinical practice.
It's practical. It's practical. But I agree. It's that I think some patients have a sort of they sort of perceive medical advice as coercion, depending on how it might be offered, kind of like you're saying.
Mm-hmm.
But really giving them their options. And then one thing I think about with our old man drug in by his wife, as you were saying, is knowing when to pick your battles. And I think that's kind of a trick, one of those nuanced aspects of motivational interviewing, of you don't have to fix everything all at once. You can say, okay, I know you don't want to do this thing, but how about we do this other thing that we wanted to talk about, right? We'll get back to the smoking next time.
Right.
And let's take this medication. We'll see how that goes. And then let's revisit that at the next visit. Because not everyone's going to be able to change everything with just a snap of their fingers.
Very true.
Or want to. Most people being fairly resistant to change, I think, is a fair characterization. But yeah, no, I think just taking things step by step is really important.
Absolutely. Now, we talked about motivational interviewing, and then, to be honest, that's the one I hear about the most. But what kind of other interviewing styles are out there, generally speaking? I don't know if they have as clear-cut of names or disciplines or anything behind them.
Yeah, no, I'd say the one that we hear the most about is probably motivational interviewing. I think there's certainly other ways to go about it. I'm not really sure. Like I said, I don't know that there are a lot of names assigned to them, or at least taught in terms of kind of what we went through.
Mm-hmm.
But in terms of like talking to patients specifically, right now there might be other ways of kind of looking at interviewing, or if you even loop feedback into the interview kind of sphere. Right.
And yeah, that brings up a good point, right? We're talking mostly about patient provider types of communication. And I think in the second half, we'll move into like peer communication, which is also very important, given that medicine is very much a team sport. But before we move on to that, one of the things, and we kind of danced around this a little bit, is that we'll very often see patients from different backgrounds, whether that's cultural, educational, different kinds of preconceived notions and things of that nature, different intellectual, people, especially in neurology, right? People with different, like maybe intellectual disability. So how do you go about, or what kind of evidence do we have to suggest different forms of communication in these settings, or trying to connect with the appropriate level of information versus diluting our message too much where the patient's not actually receiving that information in a meaningful manner?
Yeah, so I think there's a number of things that can help there. For me, I always, no matter who it is, I let the patient lead to some extent. So that's where question asking, leading with what's your understanding of your condition, or what have if you're in the hospital and you come in, you got a consult, what have the doctors told you?
Mm-hmm.
Instead of just assuming that they know X, thing Y, thing Z about their condition. So I always start there. That generally will also give you a pretty good baseline of A, how well they understand their condition, B, their level of health literacy. And then from that, because obviously you have to make some kind of judgment call on how you're going to describe what you need to, what you're going to say about their condition, their medications they need to take, treatment planning. And then teach back, I think, is also kind of a helpful thing. So summary statements on your own part while you're doing it, and then saying at the end, can you explain to me kind of what we just talked about, just to make sure we're on the same page, or what's your understanding of kind of where we're at now,
Mm-hmm.
just to get that kind of extra confirmation and to make sure that they know it well enough, both to understand what's going on and to communicate it to their other health physicians if they bring it up or anything like that.
Right. I can't tell you how many visits I've had in the office where someone comes in and they, unfortunately, their records are not in the office, and they had their care at some outside system. So they tell me I had a stroke. I'm like, oh, what happened? I was like, I don't know. I was like, oh, well, that's going to be challenging.
Yeah.
So you end up having to like really dig for that collateral information, which I think neurology is kind of a unique thing, because so many disorders affect people's memories and recollection of events. Like they may have memory loss from that specific period of time, or maybe they had a more long-term neurologic disability or deficit from like a stroke or some other kind of injury. And so you're really leaning heavily on that patient's caregiver, whether that's family, friends, what have you, and those outside records from wherever their care was given. And that's very challenging. And we see it, in the hospital as well, when, if the family member's not there at the bedside, you got to track down a phone number, hope you get through, hope that person you get through to knew the person well enough that they can tell you about what was going on beforehand. And so there's all these like things where, you're sometimes kind of operating in a little bit of a fog of war, where you don't really know all the details that would really inform your clinical decision making. And it can be quite challenging. I think neurology is somewhat unique. Probably psychiatry also faces a lot of that sort of thing, right? Anything dealing with the brain, you kind of, to borrow from literature, you kind of have sometimes an unreliable narrator. And that's especially early on in my career, I found that to be a very challenging thing. I remember, if I may, indulge in an anecdote. I had this patient who came in, and she had a bilateral occipital lobe stroke, not a huge one, but they were present, right? And I go and assess her. I'm checking her visual fields. All of a sudden, she's counting the fingers appropriately, all this kind of stuff. And I'm talking to my stroke attending, and he's like, she could see? And I was like, are you? And I was like, yeah. And he's like, are you sure? I was like, I think so. And right, like with every question, I begin to doubt myself a little bit more. And it's like, and he just says, we'll see. Yeah. And so we go into the patient's room, and he just asks her, like, what color is my shirt? And she like bombs. And she had just guessed like the right number of fingers, like 3 times in a row. And I was just like, oh my gosh. So I felt like a complete fool. And it is one of those things where you really have to question your own assumptions. If you think that the person is having impaired communication, whether that's them taking in the information or giving the information of their own history to you. And that's something that whenever I'm like rushing in the hospital, or I'm not taking the time that I should be, you get burned on it. It is a perennial fact. And so it reemphasizes, right? Like, I remember when I was an intern doing my internal medicine, we spent so much time looking through records and labs and, all these CTs and whatnot. And I find in the practice of neurology, that ratio is flipped. And I spend, like an hour talking to the patient, and I'll spend, depending on the person, right? Like 10, 15 minutes looking at their records and images, depending on how much workup they've had in the past. And a lot of times you find that the interviewing is where a lot of your diagnostic decision making happens, and a lot of that explanation of recent events. And a lot of times, as the neurologist, you're asking. A lot of times I preface this when I'm talking with patients, like, I'm going to ask you some strange questions now.
Yeah.
Because, like, especially for like seizures and things like that, right? You're asking about all these weird experiential type things. And they're like, I mean, if you're hot on the trail, right? They're like, yeah, I am having deja vu with like a weird burning smell. It's like, that's so weird. And it's like, that happens right before you lost consciousness. I'm like, yeah. I'm like, okay. And right, these are just things that most of the time people aren't asking. And I find that that's a very satisfying part of the job, is when you can kind of, you start asking these questions when you have a clinical suspicion of some entity. And yes, it's important for diagnosis, but it also, I think, provides a very strong rapport building event with the patient. Because, like, oh, finally, here's someone who's asking me about these things that I've been experiencing, and is taking the time to listen, and not just, writing it off and saying it's all in my head. And, a lot of these kinds of stories that we hear, especially from, people who are like younger women or minorities or things like this, where they kind of get dismissed a lot of times when you have these strange neurologic symptoms. So I found that, again, right, in my own practice, that this is one of the more satisfying things, is when you're able to provide this answer to someone who's been kind of looking for something to explain these strange events in their life for months or sometimes years.
Speaking of patients who are misdiagnosed or not listened to, a lot of my clinical work and research work has been in POTS, postural orthostatic tachycardia syndrome. And a lot of young females, 20s, 30s, have had symptoms, unexplained since teenage years, or, was close onset after a GI or viral, respiratory illness. And, a lot of them are told, because, symptoms being palpitations, syncope, loss of consciousness, very heterogeneous, GI stuff, changes in sweating, just, autonomic symptoms. The autonomic system is everywhere. So you can get, a whole lot of different signs, and a lot of them have migraines, IBS, sort of, those kind of things. So a lot of them are told it's just anxiety, you have an eating disorder, even though they have, poor gastric emptying. They feel not listened to. And by the time they get to us, even just, having someone listen to what they're saying and not just immediately tell them, oh, this is what it is. Even that alone builds an enormous amount of trust, which was surprising to me at first, because I was like, they must really have felt, not listened to or ignored or dismissed, kind of like you were saying, to get to that level, that even just being listened to. And it's not like we tell them, oh, we have the fix, you're going to be immediately better.
Right.
This is one of those, can be kind of chronic. It may get better. It may stay the same. It may get worse. But having that kind of answer of, okay, we're going to test you. We're not going to turn you away.
Right.
We're going to treat you symptomatically, because that's the best that we have right now. But, and then, lifestyle management and patient education. We do, online virtual, shared medical appointments that people can hop on, almost like almost like a Zoom class, I guess you could say, where it's just like, we're going to have a topic of the day, talk about, here's how you can exercise when you feel like you can't get up during the day. Here's how you can, modify some of your diet. And, even that alone, just listening to people and making them feel heard, can have an incredible impact on their health.
Right. Yeah. Right. We always think about communication as us talking, but sometimes it's just listening and, taking that information in. And that's the thing that I always think is I shouldn't say the most interesting, but something that's very interesting is that, through the course of our medical training, right, we learn all of these $5 words for all these different conditions and so on and so forth. But we have the person sitting in front of us who has some sort of experience. And that's the strange thing about neurology. And one of the phrases I really liked from Dr. Aaron Berkowitz's, I think at the preface of his textbook, he talks about the practice of imaging negative neurology, which I think is, right, it's where the art of neurology really lives, right? There's no specific test. It's for us to recognize the pathology and the way the systems are supposed to work and when there's a deviation that could be causing these symptoms. But it's taking the way that they describe their symptoms and translating that into what we know on kind of our more reductive medical side of things, and be like, can I extrapolate the way that they're describing these things into something that makes sense from like a pattern, more systemic kind of description? And, you know, it's challenging, right? It takes time. And that is the thing, I think, in modern healthcare that we really lack the most, is the time to sit and talk with these patients for a long time. And a lot of these patients, right, if they're going to their 15-minute family doctor appointment, have you ever had a POTS interview that was less than those 15 minutes or less?
They're scheduled for at least an hour usually. So
yeah, that's exactly what I'm saying, right? It's this information, right? It's very, by its nature, it's kind of nebulous. There's a lot of vagueness to it, and that's right. That's kind of the nature of how our body interprets some of these symptoms, depending on where they are in the abdomen or the chest or things like that. And they may not be like, oh yeah, it hurts when I push on my shoulder, right? That's pretty easy to suss out, relatively speaking. But it becomes this thing where if you don't have the time, you're not going to make the diagnosis, and you're not going to be able to help your patient. And I think that's just as frustrating for someone who cares about that sort of thing. But yeah, it is one of these things where taking their information, and like you said, I think one of those arts of communication is like, how can I ask the same question like 5 different ways? In as much as like, if we think of like, say, like chest pain, like as an example, right? I was with my mom a year ago, and she had a bit of a cardiac event, and I was sitting with her. We were, she had been in the ICU. She's doing all right. She's fine now, thankfully. But but the intensivist came in and like, oh, you have any chest pain or shortness of breath, or blah, the typical review of systems type litany. And then the ICU fellow and the cardiology fellow and the cardiologist and the endocrinologist, right? And so like 5-6 people in a row ask my mom if she had chest pain. And then like after the 5th person, she turns and looks at me and was like, what do they mean by chest pain? And I was just like, oh my God. So it's one of those things, right, where we assume that people know what we mean, but in reality, this is not always true. And she's an educated lady, right? She's got a master's degree. She's a school teacher. She's high functioning in the overall population bell curve. So if someone of that background doesn't understand a simple question, what we think of as simple, like chest pain, then what can we expect for someone who's less educated or less involved with the medical system and all that kind of stuff? And so it really is one of those things where if the answers, this is one of those things I always say when I have students or trainees with me, is like, if it doesn't make sense, then something's wrong. Either you're not getting the right information, or your differential diagnosis is missing something. And so you usually have to go back, get more history, right? Ask more questions. And I find that's really, you can't ever really go wrong by asking more questions, I found.
Yeah, no, I think the more questions I ask, usually the better I feel I understand, the person that I'm talking to. So that's always my default. Just really getting their perspective on the issue, like you said, and then just drawing from misunderstandings like that. Remembering I've definitely had that situation where I ask about chest pain and they say, well, not pain, really more of a pressure. And then I'm like, oh geez, how many people have said no to chest pain but felt a pressure which is, treated not too differently, as I understand, in
Right.
in cardiology. It's like, okay, we got to look at it.
Yeah.
So just asking any chest pain or pressure, or
Yes.
just making little adaptations like that as you pick up on these things can only benefit without really the cost of increased. That's not that much time to add a couple additional words for something that may be understood by a lot of people.
Right. Yeah. I find a couple of my most used questions in the course of an interview, when things aren't straightforward, clear cut, is what do you mean by that? And tell me more about that. And I find that those usually open the door to some more information, right? And I'm not an open-ended question purist by any stretch of the imagination. There's definitely times where I just want you to say yes or no to certain things, but when you're on the hunt for the diagnosis, right? Like when you're in the land of strange things and vague symptoms, you definitely have to be a little bit, cast that wider net. And I find that sometimes, I don't know, maybe it's just me, but like sometimes when I get a really good answer, I get like goosebumps. It just really, it's like, oh, I'm hot on the trail. And I don't know. That's what keeps me coming back to work every day, I suppose.
Yeah. The goosebumps moment. One for me that your story reminds me of is dizziness. That so many different things can people just describe as dizziness. And so the way that I was kind of originally taught to and adapted to asking is someone to say, oh yeah, I feel dizzy. So asking, well, what does dizziness mean to you? And I'll use this for other symptoms too. Of like, okay, well, they'll say, well, I feel off. Okay, well, what does off mean to you? Instead of just saying, well, what does that mean? Or, it keeps it less skeptical for me. Or like, okay, well, what does off mean? It's more so just, okay, what does this mean for you? Because a lot of people will I think, hone in on these certain words of like, okay, well, I'm having an off day, or I'm having a goofy day or a wonky day. Like the number of times I've heard those different words.
Yeah, and then you find out, I keep bumping my right shoulder into the door jamb, or I keep my right foot keeps like tripping on the stairs, right? It's something like my leg's cramping over and over again, and I can't straighten it out. Like, oh, well, that's not just off, is it?
Yeah.
It definitely it's all that. Again, this is one of my mentors from residency. She would always say, "What company does it keep?" Right? Everything is contextual. And any symptom in isolation may not mean that much, but it's when you ask around the symptom, and that's where the medical training comes in, right? It's like, oh, someone says dizzy. Well, I got to think about their hearing and their swallowing and their coordination, and maybe the strength in their legs or their sensation in their legs, right? All these things that could manifest as quote unquote dizziness, and you have to assess all of these systems that we know play into balance and walking and so on and so forth, right? So it goes from dizziness to like, now I'm investigating a peripheral neuropathy, right? Or maybe, some sort of vertigo or what have you. So it really does depend, right? And it's one of those things where, like you said, you ask more about it. You ask kind of around, like if you have your central chief complaint at the center of that bullseye, like what's the stuff that are kind of, in the next circle out? And sometimes that can point you in a different direction. My analogy is breaking apart, but but it really does matter in terms of making sure, right? I think we've all, and I'm sure, I know you're early in your career right now, but we come in, we think, oh, and this happened to me just recently, like, oh, young person, new onset seizures, had the MRI, the EEG, everything came back normal. Second event, so we started some medication, blah blah blah, came in, and now we're seeing like more seizures, and he's having psych changes, and we ended up sending blood testing, and it looks more like it's an autoimmune condition now. So right, the totally took a turn out of left field there, but it's one of those things where when things aren't behaving like you expect them to, right, knowing the natural history of these different conditions, and again, talking with the patient at the beginning, it's like, hey, if you notice, like, I think it is this condition, but if things worsen, if we start seeing some of these other symptoms, that's going to be wrong and we have further testing that we need to do. So setting expectations, I think that's probably one of the other things there. Like you were saying earlier, sure. Right? Like this medication, right? Blood pressure medication, probably not going to make you feel better, but hopefully it keeps you from having a heart attack or a stroke. And unfortunately, right? So in our world, like multiple sclerosis type treatments, they may not make you feel better per se, but hopefully they keep you from having recurrent flares. And setting those expectations up, I've had a number of patients over the years that I've seen in the hospital for a flare, and it's like, why'd you stop taking your medications? Like, I just wasn't, it wasn't making me feel any better. I'm like, yeah, it probably won't. And so, right, if you don't tell the people who you're prescribing a course of treatment to what it's going to do, then they're going to have false expectations and they'll be less adherent with your recommendations. And you kind of get this breakdown of the treatment plan for these people, and it can wind up causing further harm.
Yeah, I absolutely agree with that. I think even most of us in med school can relate to the person who came in and wasn't taking their blood pressure meds, or whether or not, and then in investigating, I think also this is important. If they say, I wasn't taking my blood pressure meds, asking why and delving into that, because it could be access issues.
Right.
And, that's one we see frequently as well.
I see a lot of people, it's like, it's like, that medication costs like $200 a month. I couldn't afford it. Right. It's a terrible story to hear, but it's not uncommon. And so is it the better medication? It might be the better medication, but the best medication is the one that the patient can get and can tolerate.
Yeah. So,
kind of a joke that I mean, maybe it's in poor taste, but, I do have, we get a lot of breakthrough seizures most often from med compliance. And we're like, it's like, and it's like, well, it doesn't work if you don't take it. And, as you said, sometimes they have side effects. Sometimes they don't feel well on the medication. So then you do have to dive deeper into it and ask them like, well, sometimes you can change the dose, you can change the frequency, right? There's a lot of different ways you can kind of work around those issues if you find out what they are. So it's not just enough to say like, they weren't taking their medication. This patient's not compliant, right? It's the patient's fault.
Yeah.
It could very easily be the doctor's fault if they weren't addressing what concerns the patient brought to them last time around. So it's definitely important to go to those root causes.
Yeah, no, for sure. And I think, especially with some of our POTS patients, figuring out their symptomatic treatment. Some people prefer certain side effects to others, depending on what's more important to them.
True.
If something has GI side effects, suddenly like, okay, I can't deal with any of that, or my POTS GI symptoms are really bad. Then you just got to find something else that works better for them. So it's kind of that. And I think that's also an opportunity for rapport building in both listening and saying, okay, I understand this doesn't work for you. Let's find something else that does, if there's a good option available, of course. Really just keeping that teamwork mindset and setting up that expectation for the patient of like, okay, my doctor's working with me to figure out what's going to be the best overall kind of combination of side effect inducing drugs that I'm going to have to take to kind of optimize quality of life while also treating my condition.
And that's the other thing, it's kind of frustrating to hear about. I think, again, one of my mentors during training, the practice of neurology is humbling, right? Because, in his words, because you're wrong so often. But, and I found that to be true, unfortunately. But one of the things, like, a patient will come in like, ever since I started, whatever medication, I've been having this side effect. And I was like, is that, and they would ask like, is it possible? I'm like, and I was usually like, it usually doesn't do that, but, anything's possible. So you definitely have to, right? There's what we read in the package inserts for these medications and what's reported by the FDA and all that jazz. But there's so many variables that we can't account for realistically. So it's always good to keep in mind, could this be a side effect? Well, sometimes you got to do a little trial and error, try some things out and see. And if the symptom goes away when they change medications or come off something, like, yeah, I guess it was. So I've certainly, seen some unusual side effects to things that we kind of, used pretty routinely in neurology over the years that I was like, I did not expect that to be the cause. Like someone had like this severe anemia from levetiracetam or Keppra. Like we rarely will see like some thrombocytopenia from it. Pretty uncommon, but they took him off the meds, blood count popped right back up, and can't explain it. Don't know why.
Wow.
So it's one of those things where it's like, I really wouldn't have expected that to be the cause, and it was. So I think it's, again, tying back to it, listening, keeping an open mind, and being aware that, especially for a lot of neurologic conditions, POTS being one of those, there's so many things that we don't understand in terms of like mechanism or cause or ideal treatments. So it really does keep you humble, I will say.
Yes. Well, that's what I was saying. Just like you were mentioning before about your mentor saying neurology is humbling. It certainly is, and I think we got to learn to not anchor too hard on what our thoughts are, and something that I often will tell patients is that they know their body best. They may not know their condition or how to treat it the best, but they know what they're feeling. And as long as you lead with that, now I know there's, malingering and factitious and, sometimes things happen those ways, but that shouldn't be at the forefront of your brain, generally speaking, when dealing with patients, of course. So giving them that kind of validation of, okay, I hear you. And then you got to take their kind of world of living with the condition and our world of trying to understand it and treat it and find the way to put those together the best.
Absolutely. So we've been talking a lot about, provider to patient, but what about peer to peer, to use a phrase that is much maligned in the medical community? But if we're talking with our colleagues or other medical professionals, whether they're more senior, more junior, so let's take your own experiences, going through this training program, right? You were providing feedback to more junior medical students as they're going through this training program. And you yourself were on the receiving end of it previously. So what does that look like? What are best practices?
Yeah, so it even starts very right at the beginning. First year, you're giving peer-to-peer feedback, same level, same class. Your brand new friends, you've got to tell them, here's what I think you're doing effectively and what I think that you could do better. And that in itself is a jarring opening to med school, because you have to learn how to balance. I want to tell this person they did great. I want to give them something maybe they can work on, but I also don't want to hurt their feelings.
So this isn't like a Festivus airing of grievances type situation.
Generally not.
Okay.
It is all on the record. Their physician advisor is going to be able to see everything. But so I think at the beginning, people are generally very well, and we're all, and going into medicine, generally people who might be described as perfectionists, or striving for the highest mark, because that's how, we had what we had to do in order to try to get here. And now all of a sudden, the Cleveland Clinic Lerner College of Medicine doesn't have grades. We have feedback only, as how we're graded. And, that in itself is an adjustment to begin with, but that's really how the real world works, right? We don't, spend our year working as a neurologist and at the end be like, okay, you got an A this year, good job, or you got a B, do better next year, right? It's like, okay, here's what you did effectively and here's what we can work on for next year. So that in itself is a transition. Within the peer-to-peer format, I think we improved both in the giving and receiving of feedback, which I think are two very different things. So in the giving of feedback, picking actionable feedback that at that level, you don't go too crazy with it, right? You just say, here's, you can work on your time management in your 15-minute presentations, or maybe you can do better eye contact next time, right? Just the kind of soft feedback that you can improve on, but that you can really show improvement in based on, future feedback forms. And that's kind of a longitudinal structure of you're getting feedback from your peers over like a whole year. You present that in you write up a portfolio, as we call it. So sort of a long essay using your evidence that you've gotten your feedback to prove that you both are competent in what we're supposed to be able to do and in terms of the med school requirements, and that we've improved. So it's an improvement mindset. And then when you get more into the peer, like older peer to younger peer, I think you see that evolve in terms of, so when I was working as a CS, communication skills preceptor, I had the opportunity to give a lot more feedback to younger students. And in that, having been in their shoes recently, I felt like I could give them more targeted feedback towards like, here's what I wish I had known then, or here's something that I've been doing that I wasn't doing when I was at your stage, but that really helped me take the next step. So I think it gets a little bit less like I'm worried about, hurting their feelings or them not liking me as a friend anymore, and a little bit more like, here's something that can really help you because it helped me like 2 years ago or 1 year ago.
Mm-hmm.
I didn't really feel like a power dynamic. I guess, authority is probably not the right word, but I felt like they would listen more to what I was saying in terms of advice for how to change, as opposed to, right, I'm in here with my, my very good friend who I've known for a couple years now, and I've got to give them feedback on the presentation. It's like, good job. Maybe more eye contact. It's a little bit different at that level.
Right. So feedback, obviously, you haven't been in the position where you're, the attending or the senior resident on service, providing feedback to trainees.
Mm-hmm.
So it does provide, I would say that power dynamic does shift a little bit as you move kind of more into this, for better or worse, it's the way it's structured, this hierarchical kind of system. And so, you do try, it's one of those things, and I find that I have to balance this myself also, because I have to think of like, what are the goals of this rotation, right? Which are usually, spelled out by like the ACGME or, the medical school
Mm-hmm.
for, student rotations and stuff like that. Like, what do they hope for them to gain in terms of skills and experiences and so on? And so it's particularly challenging, I think, for medical students, right? Because you don't want to like write some kind of review that could be considered as like scathing or things like that. So I usually do try to do more informal verbal feedback rather than writing like a long thing like, hey, your assessments were pretty weak despite our talking about them, and you didn't really flesh out your thought process, blah blah blah, right? It's like these things that we kind of
Mm-hmm.
hope that people are getting better at over the course of a few weeks.
Mm-hmm.
And, you don't want to just write the ubiquitous read more in terms of your student feedback either, right? So from
Mm-hmm.
your perspective on the receiving end, on clinical rotations and things like that, what do you think has been the most useful way of getting feedback, whether like in the moment, at the end of the rotation, in your written assessments or what have you?
Yeah, so I think there's, it gets, part of it depends on how long your rotation is. So let's imagine we have a 1 week rotation,
right?
And then and then your attending changes every week or whatever it is. I found it most helpful to have kind of a midpoint verbal feedback. And so you can assess, okay, how am I doing? What's working effectively? What could I, work on in these last couple of days? And then the endpoint. So whenever that attending or your senior resident or whoever you're working most closely with is switching off a service, saying, okay, here's how we've, grown since then, and kind of just overarching feedback. I think written feedback can certainly be helpful. It's easier to go back and look at and review later on because it's always there. But for me, it's those kind of verbal, kind of candid, just conversations about, okay, how did things go? It can be more comfortable that way. You have a chance to respond as well. Written feedback is just kind of, they write it down and then it's just out there. You don't have a chance really to say, okay, well, this is what I was trying to do, or in this situation, here's what I was thinking, or just to acknowledge, like, yeah, I think I could do better on that. And I think acknowledging that you have room to grow is also a strength and reflects well on you as a lifelong learner, as people like to say.
Yes.
But yeah, no, I think for me, it's been the verbal feedback that's the most helpful and some of the most memorable kind of formative experiences.
And I think it's important to emphasize, there are some rotations where that will be more structured, where the attending, it's kind of built into the rotation almost. But there are many rotations where, the attending is busy. Maybe they're understaffed.
Mm-hmm.
I'm sure that never happens in medicine anyway. But
Never.
if it is entirely possible, they will forget to give you feedback. So I think as a student or a trainee, it is important to seek that out as well if you really have a genuine interest in improving yourself. And I would say doubly important if, say, you're applying to that same specialty, you want to try and get a letter of recommendation, you really need to be kind of going after that and being what they might call in the business world managing up a little bit. In terms of like, hey, Dr. So-and-so, I'd really like your opinion on how I'm doing on this rotation and what I can do to really, perform well by the end of this rotation, because I'm thinking of applying to the specialty and, so on. But it is important to set those expectations early in the rotation, because if you want a letter of recommendation, you're only with this person for 1 week and, they didn't see you that much and your performance was a little mediocre, they're not going to write you a great letter of recommendation, that's for sure. And so you definitely need to make sure that you're doing what you can to put your best foot forward. And again, right, it kind of comes to that communication aspect of things where you're telling them like, hey, I'm interested, I want to apply to this, and I would like to do well enough on this rotation to get a letter of recommendation from you.
Mm-hmm.
So what do I need to do that? And then executing on that midpoint, find out like, am I heading in the right direction? And hopefully by the end of that period together, you've done well enough that you've, demonstrated, improvement, or, whether or not you're like, there's always like subspecialties where it's going to be really hard to like be like really impressive, but it's the expectation of what do I expect from a third year or a fourth year medical student versus what do I expect from a third or a fourth year resident, right? It's entirely different skill sets. So I think it's really important, because I'll sometimes get requests for like letters of recommendation, like near the end of the rotation. And I'm just like, I can write one, but it's not going to be great. And I hate saying that, but it's the truth, right?
Yeah.
So it is important to make sure that you're like really excelling, right? You want those, especially with residency applications being the way they are these days. You want to do everything you can to like get a really stellar letter. And just having those conversations, I think, is it will dramatically increase your chances as far as that piece of things go. I don't know. What's your experience as someone more recent?
As someone who went through AIs in the last 3 months.
Yes.
Very recent takes. It is hard to open those conversations at times. It's easier with the residents, especially those that you're working closely with. I would often seek feedback from them kind of at midpoint. And, my favorite question is there anything I can do to be helpful right now? Just throwing those things out there into the wind to be like, I'm looking for ways to be helpful. But then when getting feedback, making it a priority to whatever that thing is of, I want to see you work on your differential diagnosis. I want to see you going to check on your patients by yourself in the afternoon and just giving them updates, whatever it is. Doing those things is going to make you look the most impressive beyond just starting good and ending good, because it's like, okay, this person wants to improve. And someone who wants to improve is someone who's going to work hard, who's going to be a good team player. I think that reflects even stronger than just being good alone. For me personally, as a person who is constantly trying to improve, because there's room to. And when with the attending, sometimes it's hard. Sometimes you don't see them very much. They pop in for rounds. You walk around as a large team. And that's just the way it is, because they're insanely busy and they've got a team of 8 residents and 1 medical student, and they're trying to talk to everybody.
Right.
So it can be hard, but catching those moments where it's like, okay, now's my time. Like it hits in your brain of like, okay, I've got a chance here. Just asking, do you have any feedback? And from what I've heard from, attendings that I'm close to, they love hearing that.
Yeah.
They love giving feedback. They love people who want to get better and to kind of help in that process. And it doesn't even have to be a long conversation. You just a minute or two, and that can make a big difference.
Right. And I do think again, right, this is my perspective. I'm not currently at a neurology training program, but when we would have medical students who are, there on like a sub-I rotation or audition rotation, or even just third years who were interested in neurology or considering it, it's like you get brought into the inner fold almost immediately. So it's a double-edged sword, right? You will get the attention if they know that you're interested in neurology,
Mm-hmm.
but the expectations go up immediately. So they're going to expect you to be doing a lot more,
Mm-hmm.
but you will get that that attention and that personalized touch if you're able to kind of meet those expectations.
Mm-hmm.
I kind of think of it as like, joining a cult, right? It's like, hey, I'm interested in joining your cult. Like, oh, really? Let me tell you about about the good news.
Welcome to our initiation
Yes,
rites.
yes. So here's what you have to do. Here's your hammer, and here's your tuning fork. So, but it really is true. Like, if I've worked with a number of medical students, even where I am now, and as soon as they say they're interested in neurology, I'm like, all right, let's talk about that and what we need to do to, get your best foot forward and get all those things kind of lined up over the next year. And kind of,
Mm-hmm.
right, it's a small community, putting you in touch with people at local institutions and, getting all those things moving that are going to give them the best chance to get into a program that they want to.
Mm-hmm.
And I don't know, has that been your experience as well? Like when you've expressed that you're like, oh, I'm interested in applying to neurology.
Mm-hmm. Yeah, no, I think you definitely get more direct attention as opposed to my surgery rotation where I said I was interested in neurology, and the opposite happened, which is
right. You
which is
like
fair.
fade into the wallpaper,
which I didn't mind too much, but no, it was good. There was a lot of I learned a lot through that rotation as well. But the I'd say on my neurology rotations, you could definitely see the expectations go up, but not in terms of necessarily of being correct all the time, which I think is a common, just sort of instinctual assumption that medical students or people who are being evaluated think that they have to be right all the time. And it's distressing when you're not. And I think it's hard to get away from that. But having, it's more about showing that you want to learn, that you want to be part of that kind of team, that you're comfortable working with kind of the elements of that specialty. And then your patient care and how much your patients, respond to you and like you within the, the confines of their personality and, and all that. But that's what stuck out to me the most, that it wasn't, when expectations went up, it wasn't expectations that I know everything. It was that expectations that I would want to learn things that somebody on that rotation who wasn't interested in neurology would not be interested in.
Right. And that's, similarly from the attending to the trainee side of things, it is important to set those expectations. Like, what do I expect for a third year student, for a fourth year student, for someone on a sub-I, for a junior resident, a senior resident, right? These are all different skill sets that people should have mastered as they go up the ladder. And saying like, or I should say for rotating residents, right? So for people who come in from internal medicine or family medicine or emergency medicine onto the neurology service, the expectations are different. They'll have different skill sets that they're bringing to the table. A lot of times I say, and this is right, if you already knew everything that you needed to know to practice neurology, well, there wouldn't be much point in the training, would there?
Yes.
And I think, right, to your point, reassuring people that this is in fact the case. What do I expect? I expect you to be able to talk to the patient, gather a story, put the story together in a comprehensive and coherent way, and then create a differential diagnosis, right? I don't know that you need to have the correct diagnosis you want. There's a lot of weird stuff in neurology. Sometimes I got to do some reading too. And but the point is like, hey, let's engage in the thinking exercises that go along with the practice of neurology, right? The localization and the timeline, and right, kind of putting together an appropriate list of possibilities and engaging in that thought exercise more than everything, right? I just want to know, can you think? That's really what I want to see, right? Can you talk to the patient, get the information, and think about it?
Right.
And think about things that make sense, right? Not everything is a stroke. Not everything is a seizure. There's other stuff out there. Let's think about that. So I think that's the most useful part of neurology is that I think I'm probably painting with too broad of a brush, but I think that gets lost a lot in other specialties. But in neurology, we're so dependent on it, that information, that we can't, even if we wanted to, we couldn't get away from it because we would just be bad at our jobs.
Yeah, no, I think that's totally true. And in terms of like when you evolve from that year 3, like, oh, I'm interested in neurology. Well, let's see if you can think like a neurologist. You go onto the AI. It's like, okay, can you work like a neurologist? And do you want to? Right? Like,
Right.
will you put in the teamwork? Will you work? Improve documentation? Will you take care of your patients and review their charts and catch? Okay, maybe we should have them on this medication or that. And all those things don't necessarily have to happen, but are you looking for it? And then, are you at that level of, okay, this person could be an intern in our institution and be successful?
Right. And so since you said the magic words, there is a great book out there called How to Think Like a Neurologist, that I do recommend. I actually interviewed the author on a past, it's almost been 2 years ago, I think now, Dr. Ethan Meltzer. But very good book, and it's just exactly what it says on the tin. So you kind of walk through, and each one is a little case, and they're like, let's think about this. What's the localization? What's the time course? What's the syndrome? Et cetera, et cetera. And it's exactly that. Like, how do we, train our minds to think like a classical neurologist? And it's different than how an internist usually approaches a neurologic problem, or an emergency physician or family physician. And I think it's good to have this different way of thinking, because the way that we tend to create our differential diagnoses is, I think, a little unique as far as that goes. But just because the nervous system is what it is, right? But but I think it's a very interesting thought experiment to engage in. And when you're first starting out, like, I wish I had had that book when I was a junior resident. It was very helpful. And something that I just kind of had to build over time through trial and error. But it's really, I think, helped me at my stage of the career in terms of crystallizing how right? Again, we're talking about communication for those who forgot as we were rambling. But the kind of the transmission of information. So from me as an instructor to my students, like, why do I think this? It's not just like gestalt, I mean, sometimes it is, but we need to try and put those gestalts into words and have reasoning and a rationale behind what we do. And I mean, how it's too often that we'll see, like, oh, why did they put you on this medication? Why they do X, Y, or Z? It's like, oh, I don't know. That's just what they did. And you don't find anything in the documentation. You don't find any reason for something. And I'm always torn between my twin desires, like, I shouldn't say desires, but my twin thoughts of, like, there must be a reason for why this person did this, versus that seems like a really stupid thing to have done, right? So I just kind of ping pong back and forth, and I'm just like, you kind of have to remind yourself, like, these are also medical professionals. There may have been a piece of information that I don't have that justifies what they were doing at that time, right?
Yeah.
So it's always easy to take the easy way out and say, like, that's dumb. They shouldn't have done that, right? But in reality, there may have been a reason. I just don't know it. And so that's always the hard part. So I think also to kind of tie in our third piece of communication is, like, the medical record itself and these paper charts. And not necessarily the focus of our conversation today, but I think charting is somewhat important, although we all hate it because of the burden that insurance has put on us. But I think it's important to document, like, what you're thinking and why you're thinking it and what you intend to do about it. Everything else is window dressing, more or less. But if you can at least document that, so someone picks up your notes, like, oh, Dr. Cantrell, he thinks this person has, whatever, migraines, and they're trying this medication, and they're going to see him back in 2 months and see if it's working or not. And it's like, oh, I know everything I need to know about this particular problem that they're dealing with. And that's really kind of important, right? It's like, if we just do kind of shoddy notes and they don't explain our thought process, there will be a doctor who comes along and says like, oh, that guy, he doesn't know what the heck he's talking about. He's just, he's just throwing darts at the wall.
Yeah.
And so you don't want to be that doctor, or at the very least, you shouldn't be perceived as that doctor because of poor documentation. You should at the very least say like why you're doing something and what you think it is. It doesn't necessarily need to be, a 3-page essay. Although certainly in your clinical experience, right, those POTS patients, sometimes the histories are quite extensive.
They can be. They've been through a lot.
Yes, right. Especially if you're working in an autonomics referral center. That's not the first port of call for many of these people. There's been a lot of ink spilled previous to them getting to you.
Yes.
But yeah, so that's kind of my perspective. But it's that third way of communicating, right? Very often we're communicating asynchronously and remotely to our other colleagues, and medicine is so fragmented that we may not be getting on the phone and talking to them. But if our documentation can communicate what we're thinking to them, then that can be almost as good.
Yeah, no, I usually when I'm writing notes, and obviously I'm still early on in the stages here, but I usually, at least for assessment and plan or HPI, those kind of narrative sections, I think of like if you're talking to, like if you're presenting it to a doctor you don't know,
right?
Just any one individual, just to lower the pressure on yourself.
Right.
Just one individual that you don't know, so that they can look at it. It's just imagine you're talking it to them.
Right.
I know some people like to dictate. I'm more of a typer than a talker out loud, but I think that can kind of help keep it kind of conversational and easy to read as well.
Yeah.
Easy to read and comprehend.
I always think, again, I can't place the quote, and this is more of a paraphrase than anything, but I'll sometimes get asked by students or residents, like, how long should my note be? Or how long should my HPI or my assessment be? And you may have picked this up. I tend to give tongue-in-cheek answers most of the time. But I'll say it should be as long as it needs to be and no longer. So
yeah. It's good advice.
But I mean, it's true, right? We've all read the notes that are, like literally one sentence and just like, I don't know what the heck is happening here. And then on the complete opposite end of the spectrum, there's this long winding note full of extraneous information. It's not in a chronological order, right? It's a narrative disaster. And so you spend so much time, right? It's probably exactly what the patient said in the visit, but you as the provider, as the physician or the APP or whomever, need to translate that information into something so that when it lands on somebody else's desk, or when they come back to see you in like 3-6 months or whatever, you're not having to spend 20 minutes reading these records that maybe you yourself wrote to yourself to figure out what was I thinking, a few months ago. So be kind to your future self, be kind to your colleagues, I would say, is that on that front. So any final thoughts about communication? If in your experience, seeing, obviously you got your experience at Cleveland Clinic, working with perhaps students from other training programs or residents who came from other training backgrounds, I know communication training like this is not necessarily universal. It's certainly gaining popularity in a lot of places, but what's your bird's eye view, again, just anecdotally, about communication training in medicine and where it stands for kind of the current generation of physicians versus, so let's say, the older generation of physicians, and where are some areas of improvement in our practice at present?
Sure. No, I think that first of all, I loved communication skills as a first and second year medical student. It was, I think, one of the highlights, both because I enjoyed the practice of getting better at communicating in general. And my first year and like half a second year of medical school was during the COVID pandemic. So that was one of the few times we got to come in and be in person together.
Oh, that's rough.
So that helped a lot. But I think there's, it's not training people or medical students to communicate one way. It's not, we're not teaching them all to be the same physician. It's more so we're providing them with like a toolkit, and they can choose which of those tools they want to use and how they want to use them within their own unique style. So in a way, it's more so teaching med students how to be themselves with patients. And that's the way that I look at it. And the feedback that I gave was mostly targeted towards, okay, this is, you have these strengths as a person, use them, and then take these other things that we like to teach you, the kind of strategies and things, and try them out, see if you like them, change them a little bit if you want to. And, what works best for you. And that leads me into kind of I think one of the most important things that I took away from it and tried to teach to my students was the practice of self-reflection. We've talked a lot about talking to other people. How do we talk to ourselves?
Ooh, good point.
And that is really hard because the very first day you do your standardized patient encounter, and then someone, three of your friends are sitting there looking at you, and a couple preceptors looking at you saying, okay, how do you think you did? And everyone immediately says, well, I should have done this. I should have done that. I didn't like how I did this. My eye contact was bad. Like that's where our minds go just naturally. Because we focus on what we didn't do well, that perfectionist mindset. And so that's the hardest thing is to teach these students. And it was hard for me to learn myself, to start with what we call reinforcing feedback, try to stay away from positive and negative. Reinforcing feedback. Here's what I think worked effectively for me. I think that my eye contact is improved. I think that I really built rapport with this patient by talking about, this aspect of their family life they brought up. And then here's what I would work on next time, or what I could have done differently. Next time I want to work on thing X, thing Y, whatever it is. And that has become a common practice for me. Every patient experience that I have is now an opportunity for self-reflection. I think I did these things effectively. I think next time I would want to work on that. And just another kind of corollary to that is I try to stay away during self-reflection from the word should as much as possible. Because immediately I should have done this, I should have done that. We're kind of assigning blame to ourselves for something that we perceive we should have been doing, as opposed to, well, I could have done this differently. Maybe next time I can try that and see if it'll work better for me. And that I feel like it's all mindset. It's all practice. It's whatever works best for you. But that self-reflection component is, beyond even the learning how to communicate with others. It's helped me beyond medicine, beyond talking with patients and peers, but just in my personal day-to-day life.
No, those are great points. That negative self-talk is, I think, definitely something that most people in medicine struggle with for that exact reason that you said, right? We're all used to being high achieving, right? You can't be wrong. You have to be right always. And so anything that is wrong is bad. And it's, it doesn't help, right? It doesn't make you feel better. It doesn't make your performance better. So it is very useful and challenging to kind of reframe those things. And I kind of hate this, right? It's become like a bit of corporate speak, right? These opportunities for improvement, quote unquote. But in reality, I mean, when you're saying it to yourself, it's a different thing than when corporate's saying like, oh, hey, 50 people quit. We have these opportunities for growth. Different context, but
yes,
but it really is true, right? We do have these opportunities, and it's perhaps gotten a bit of a bad rap due to online discourse, but having this growth mindset, right, which ties into being that lifelong learner, looking to constantly improve our skills, and I think those are really important things, and it's very easy for us to kind of dismiss these, again, like as we said kind of near the beginning, these soft skills as something. But I've known so many physicians where, outside of the clinical setting, they're super nice, super friendly, but then you get them in to a patient encounter and they are all stiff and rigid and kind of sweaty, and nothing against sweaty people, but I am at times amongst them. But it is one of those things where, it's like, dude, what's going on? These people just their entire demeanor changes. And it goes back to what you were saying, that they are not being themselves. And it is one of those things where that self-talk, you have to be first okay with being yourself, to be yourself in front of somebody else, especially when you're you're engaging with someone in a vulnerable position, right? There's a sharing of information,
Mm-hmm.
and sometimes you're sharing different experiences. Some of those may be quite vulnerable in nature, depending on the conversation. And if you're not comfortable with yourself, you're not going to be comfortable having these conversations. And I think something we all struggle with when we first enter clinical practice, in particular, we're asking about things like sexual history, illicit drug use, things like this, things that are not considered a polite conversation, quote unquote.
Mm-hmm.
And so you're kind of moving into this different realm of what is socially acceptable, right? You're assuming this mantle of a healthcare provider, and to an extent, right? If I'm walking through the grocery store, I'm not asking, the random lady in the produce aisle, like, oh, hey, how many packs of cigarettes a day do you smoke? Or, have you ever had hepatitis? Or, all these
Right.
things that in a clinical setting would be entirely within the realm of conversation. So it's this reframing of like, what is it okay for me to do and to ask in this setting versus my normal social interactions?
Mm-hmm.
And that does have a steep learning curve, and some people struggle with that transition quite a lot. I know I did the first couple of years that I was in clinical years in med school and as an intern, but ultimately, right, you got to have these conversations. So you just kind of got to tear the Band-Aid off and get comfortable with it. I mean, it's not helpful advice. I apologize, but that was how I did it for me. And it is, right. It's one of these things where it's a weird social phenomenon where we're expected to quote unquote be ourselves, but we also have to be, the face of their healthcare administration.
Mm-hmm.
And so you kind of have to be yourself, but also be something else at the same time. It's this weird superimposition of these different social roles.
Mm-hmm.
So it can be hard, especially if you're, like I said, not comfortable with kind of who you are. I don't know. I got kind of metaphysical there for a second. What are your thoughts about all that?
No, I love it. I think that's really where the communication skills course helped me was, if it's almost like you're performing in a way at first, right? You're pretending to be
Mm-hmm.
a doctor. You're pretending to be a medical student who feels like they're part of the care team. That was my growth journey in the first,
Mm-hmm.
Year or two, was realizing, okay, I am part of the care team. The questions I'm asking can matter. And I'm not just inconveniencing this patient by talking to them before the doctor does. But kind of realizing what's holding you back, what is
Mm-hmm.
stopping you from being yourself and that doctor at the same time.
Right.
And doing that in front of sort of like in a environment that's established to be like a safe learning environment. You can do anything, you can say anything, and we're just going to give you feedback and grow all together.
Mm-hmm.
That was huge. And it almost, like, in a way, when I was alone with patients, I felt more comfortable. Like, it made being alone with patients feel more comfortable than when I was being watched.
Oh yeah.
Because it's like all of a sudden you're putting all this pressure on yourself. And it's really you doing it to yourself. It's just, this is how it works, because everyone's watching you with open mind and, supportive and everything. But that for me was one of the biggest things.
Mm-hmm.
was finding myself as a communicator, and being able to be, just the way I'm talking to you now is the same way I talk to patients.
Right.
And we joke around when appropriate and laugh and comment on things and feel like what we're saying is important to them.
Right.
That's what it has to be.
That's exactly right. And that's actually one of the pieces of feedback I've given. Perhaps, again, I can't keep from joking. It's perhaps to the point of a personality flaw, but it's like, just talk to people like they're people, right? Don't turn into like a lizard person when you're in a patient encounter. Like you've forgotten what do humans do during normal social situations. And again, I know there are people who are like kind of on autism spectrum and things like that will struggle more with some of those social cues and things like that. But when someone is acting normally outside of the room and then their whole demeanor changes, that's more what I'm kind of intimating at.
Mm-hmm.
And it is one of those things where, you just talk to them like you would talk to anybody else. And that that's going to solve a lot of your problems, I think, for anyone out there who's kind of struggling with that. I kind of think back to, kind of like classical, like ethics, the big question, what does it mean to be a good person? And it's like, well, what does a good person do? They take care of their family. They are, responsible members of the community, blah, blah, blah. The rest of the details. But you do the things that a good person does. Does that mean that I am good? Right? It's the same thing for becoming a physician. I do the things that a good physician does. Am I a good physician? I don't know. But at some point, right, it's not just the things that you are doing. And right, I've been reading too much metaphysics lately, but it's like the doing leads into becoming, right? So by doing the thing, it's kind of the fancy version of fake it till you make it, right? But but you're not faking it. You are doing it, right? You are doing the thing. And so by doing the thing, eventually I heard this said, if you want to be the noun, you have to do the verb. And I really liked that. A little more,
That's
pithy,
cool.
right? So if I'm doctoring, eventually I become the doctor. So, and it's one of those things where you accumulate these skills over time. And, communication, as we've said, is one of these very fundamental skills. So fundamental, it's almost overlooked in some arenas. And I think it's one of those things where we spend so much time like learning about physiology and anatomy and pharmacology, and the litany goes on forever, but we almost neglect this beginning point, right? If we don't talk to the patients, if we don't tell them like, hey, we're doing this because of this, then all of it's just so much wasted energy. We do the tests, we make the recommendations, the plan falls apart because we didn't communicate it. So anyway, I am diverging significantly, but I just find it a very interesting phenomenon, in the course of like language and thought and all these kinds of things that are wrapped up in like the underpinnings of communication.
Yeah, I'm totally with you on that. I think communications become almost even a kind of a passion of mine within the context of education, and even just myself, self-reflection. How can I improve? How are the things that I say perceived by others, and how does that help or hurt me in my goal to help them? And it's a constant day by day journey. We're going to keep on doing it on my end, and I hope medical students out there keep on learning as well and keep improving too.
Yeah. What's that? There was a Pink Floyd song, I think, out there. It was like, just keep talking. So from one of their less popular albums, but that's okay. It's a good song, but that's the point, right? It is just keep talking, right? Even if you're not good at it to begin with, keep practice, just like anything. It's the practice of medicine. It's the practice of communication. If you don't do something, you'll never get better at it. And I think that's a great point to end on, is just keep talking, just keep communicating, just keep working at it.
I love that.
Any final thoughts? Where should people reach out to you if they want to get in touch with you online, or do you have any projects to plug?
We've got POTS research out there. Search for Dr. Robert Wilson, and you'll find some of our POTS work. Found some interesting things related to post-COVID syndrome and POTS, and a number of other things. Low-dose naltrexone we've been working on as potential therapy. And then, feel free to reach out. My email is cantrec@ccf.org. And appreciate you, Dr. Kentris, for giving me the chance to talk about this today.
No, this is a really fun conversation. I appreciate you taking the time, especially as we go into interview season. I know how busy that gets for people. And you can, of course, find me online. Our website is theneurotransmitters.com, and you can find me mostly on X, formerly known as Twitter, @drkentris, Kentris. And you can always email us from the website as well. Chris, thanks again. I really appreciate it. And good luck with all the research.
Thank you. Good luck to you as well.
Thank you.